Kerala. Sir has an interventional medical procedure.
Dr. Bajwa, some background noise.
I think it's Dr. Divya's maybe because
Sir,
Divya.
she's not audible, sir.
Dr. Divya, you are not audible. Where is she now?
Dr. Apurva was speaking, sir.
Apurva continues if you can continue. Apurva.
Okay, sir. So I'll introduce the next panelist, that is Dr. Bijoy Chakravarti. He is an associate professor, Department of Anesthesiology and Pain Medicine at Jubilee Mission Medical College and Research Institute, Thrissur, Kerala. And his clinical interests are in fields of interventional pain procedures and chronic pain management with focus on back pain and knee pain, and also in ultrasound and fluoroscopic procedures. To his credit, he has 3 international publications and he's delivered more than 50 guest lectures all over India. And coming to the next, we welcome you, sir. Yeah, the next speaker is Dr. Nidhi Bhatia. She is a professor at PGI Chandigarh, and she's a core faculty for the DM Trauma Anesthesia and Acute Care. Her experience is in clinical interest is ultrasound guided regional analgesia, obstetric anesthesia and airway management, as well as resuscitation. She's a founder member and treasurer of Society of Trauma Anesthesia and Critical Care, and she's the national EC member of AOA, and she has more than 90 publications to her honor, and she's authored more than 15 chapters in various books, and she's the chief editor of book on acute trauma in developing countries. We welcome you, ma'am, to this panel discussion.
Thank you so much. Thank you for having me.
The next panelist is Dr. S.K. Maniruzam. He is a consultant anesthesiologist at Kolkata, and also he's a consultant anesthesiologist for the Smile Train program. He is the founder member of Anesthesia Society for Bariatric and ex-EC member of Kolkata Society of Anesthesiologists. His expertise is in bariatric anesthesia, cleft anesthesia, trauma, and CPR and regional nerve blocks, and he has delivered more than 30 guest lectures all over India. We welcome you, sir, to this panel discussion. Yeah. Coming to our next panelist, that is Dr. Shilpa Tivaskar. She's a consultant at Bhakti Vedant Hospital, Thane, and she's also an honorary secretary of ISA Borivali City Chapter, and she's a EC member of ISA West Zone. She is presently reviewer of IJA and managing committee member of IMA and AMC. She specializes in critical care airway management, and she's a BCLS ACLS instructor. She has delivered multiple lectures at local, state, and national level conferences. She was the organizing secretary of ISA Maharashtra CME in 2022. She has 2 publications, and she's won the award of Best Thesis Oral Presentation. We welcome you, ma'am, to this panel discussion.
Thank you so much, madam, for the kind.
And last but not least, let me introduce the moderator of today's session. This is Dr. Anju Gupta. She's Assistant Professor of All India Institute of Medical Sciences, Delhi. And her experience is in regional anesthesia, pediatric anesthesia, and airway management. And she's an editor for Barash Clinical Anesthesia textbook, Dorsch and Dorsch, and airway manual. And she's an assistant editor of JOACP and IJRA. And she has delivered many guest lectures in various conferences. We welcome you, ma'am, to moderate this session. I hand over now to Dr. Anju Gupta.
Thank you so much, Dr. Apurva.
Anju, just 1 minute.
Yes.
We also welcome our very senior anesthesiologist sitting right in front of me, Dr. Asit Vaishnav sir from Rajkot. He has made a special time, so his presence will be immense joy for us actually today. So welcome, sir. Now, Dr. Anju, please carry on.
Welcome, sir. Thank you for honoring us with your presence. First of all, I would like to thank our honorary secretary for this opportunity to.
No, thank you. Just start here. No, thank you. Start.
Okay, sir. So we are fortunate to have an elite panel of experts today who all have a extensive regional anesthesia experience. And so I'll begin my first question. Can I ask Dr. Manirizam to please address this question? Dr. Manirizam, do you think that the importance of regional anesthesia stays the same for the patient, for us who are, for people who are working in resource limited setup, as it is for the tertiary care setup? So do you feel that it is important for the private practitioners, for people who are working in low resource setup, to also practice and learn regional anesthesia?
Thank you, sir, for allowing me to be here. Let me straightway go to the topic. Yes. So the question that, ma'am, you have asked is regarding peripheral setups and low resource setup, resource limited setup rather. So there are two things: one, resource limited and peripheral. It's not always that a resource limited setup should be located in a peripheral area, but mostly they are. Now, right now, I can see there are 136 participants, and all of them are anesthesiologists. I'm sure many of them must have worked in a low resource peripheral setup. Let me take you all, just have a small trip to a resource limited peripheral setup. How do they look like? Usually all the setups are usually located in a suburb area where you find many small nursing homes. They all are clumped together in a very small radius. You can see a lot of nursing homes together. There's a very tight competition between all these nursing homes regarding patients and financial matters. All the surgeons, those who are working, along with the anesthesiologists who are working there, they all are working there for a very, very meager remuneration. And most of the patients are basically nursing home patients. Practically, patients are like brought in by the nursing homes. Like doctors have picked up patients from their chamber are very rare. And these patients who are coming, they are in fact very, very low demanding. They're not that high demanding patient. They are not that finicky. And so the urge to do some extraordinary work in these setups are also very rare to the doctors who are working there.
Dr. Manirizam, sir, your voice is quite low. What I'm doing, I'm muting everybody for the moment. You just unmute yourself to speak again, please. Huh? Now you unmute yourself, please.
Yeah. Am I better audible now?
Sir, you can bring the speaker a little closer to you, or laptop, your laptop closer to you.
Is it better now?
Slightly better, sir, not completely better.
Can you put off this fan? Just let me put off the fan. Is it better now, sir?
Yeah, little better, sir, because the disturbing sound has gone. So it's better, looking better.
Okay. So what I was saying, the patients are usually not very that high demanding patients, less finicky patients. And if you enter into the OT setup, it has got like bare minimum setup. You can hardly found you can mostly found a Boyle's apparatus. That too, at times, mostly they are refurbished Boyle apparatus, not very high-end thing. Like surgeons and anesthetists both have to run away to some other nursing home for the next case. If you look at the Boyle's apparatus, you cannot find any vaporizer. Drugs are lying mostly outside the refrigerator. You are very skeptical about the potency of the drug, how good they'll be working. You forget about PNS for regional anesthesia. Forget about the USG. PNS, in fact, PNS machine, nerve stimulator machines are not usually available unless there's some enthusiastic anesthesiologist who's carrying his own PNS machine or nerve stimulator machine. And question of dedicated USG machine, just forget it. But at times, surprisingly, I found at times, since all these nursing homes, they have USG machines for diagnostic purposes. If you insist on them, they can get you one ultrasound machine, which they do have downstairs for their diagnostic purpose. Okay. And if you face any complication, they do have a ICU setup. where you can find some monitors and some residential doctors or some technicians who are just maintaining them. So working in this kind of situations where giving a GA is really at times really very scary, the importance of regional anesthesia is like very supreme. Like you have to have a very rigid skill of regional anesthesia to work in these situations, because you always tend to avoid general anesthesia, and the regional anesthesia here is particularly for anesthesia purpose, as contrary to in tertiary setup where a patient is surrounded by consultants, registrars, junior doctors, so many doctors around, where you have very high-end anesthesia workstations with all sorts of vaporizer, ultrasound machine, all sorts of gadgets, PNS machine, everything. Patients are very finicky. They won't allow you to put in an IV channel. So here, in this tertiary care setup, the purpose of regional anesthesia is mostly because of post-op analgesia rather than post-op like intra-op anesthesia. So the importance here in peripheral setup is really, really very high of a regional anesthesia. If you really want to do good in a peripheral setup, you must be knowing, you must be very well accustomed with regional anesthesia, different blocks, and it has to be very sure shot block. Because if you use one GA, you're increasing the cost, everything. You're increasing the time, you're increasing the manpower, everything. So you must know good regional anesthesia to work in peripheral setup.
Thank you, Dr. Maniruzaman, for your lucid description of challenges which are faced in private setup. You are absolutely right in most of the points that you mentioned, that there are so many challenges. There is lack of infrastructure, there is lack of drugs, there is lack of equipment, and the most important point is that it is important and it is useful for private setup as well. That is what was our point of discussion. That is it as useful for the private setup as it is for the tertiary care setup. So it is definitely useful, and as you mentioned that it is mostly utilized for anesthesia purpose rather than analgesia purpose. So it is because it is so much of cost saving, and it saves the patient from receiving general anesthesia, saves cost, and then patient receives just a few drugs and the patient gets a general regional anesthesia, which is a complete anesthesia. So now can I address the next question to Dr. Ajay Hegde? The question is that how can the private practitioners get mentally prepared to adopt regional anesthesia techniques in entirety, as well as at the same time convincing the surgeon and counseling the patients at the same time regarding its need and benefits. As Dr. Maniruzaman also mentioned that it is very difficult in private setups and you have to be sure shot, your block has to be sure shot, but not everyone will be that adept at regional anesthesia everywhere, even be it a private setup or be it a tertiary care setup. You have a learning phase. Initially you will be a learner, so you need to have a training and you need to have a exposure, and in your early phases you might be taking more time, then convincing the patient that the patient will be receiving needles, and the private practitioner himself, the practitioner need to have a mental this orientation for utilizing regional anesthesia, because it does not provide any additional remuneration for the private practitioner. So we need to be motivated enough to use it. So Dr. Ajay, can you please answer this question, that are the private practitioners currently they are motivated enough to counsel the patient as well as the surgeons regarding the needs and the benefits?
Thank you for the opportunity. Yes, you correctly said. First thing is to get ourselves the sufficient skills and expertise in performing different peripheral nerve blocks, either USD guided or PNS guided, depending on the availability. And this can be done by regularly attending various workshops, conferences, and specialized training programs, which is happening time and again in the different states and states. And at the same time, we should have an effective communication with surgeons, which is very important for understanding. We should understand their concerns and expectations regarding the regional anesthesia. We should be able to explain them the benefit and safety profile of the regional anesthesia techniques, emphasizing on the faster recovery, safety profile of the anesthesia, reduced post-operative pain, reduced opioid consumption in the post-op period, and as well as the potential for better surgical outcomes. Addressing any misconceptions or doubts they may have regarding the blocks also is helpful. And from my personal experience, it's always better to start with the simple cases in the beginning, small cases where they should get accustomed and comfortable and confident in our ability to give blocks and do the surgeries under block. And as the trust builds up and the successful outcome, we can show the successful outcomes. So they will be more willing to adapt the regional anesthesia for even the complex cases. And patient counseling, again, it's very important. From the pre-anesthetic examination time onwards, we should discuss with the patients regarding the benefits and potential risks of the regional anesthesia, addressing their concerns and answering their questions in the simplest terms possible. And we should ensure that they have the clear understanding of the various options available to them, and actively you should involve them in the decision-making process.
Thank you, Dr. Ajay. You have rightly mentioned that the communication is the key for the practitioner to practice the regional anesthesia successfully. And as somebody has mentioned that for a regional anesthesia to be successfully practiced, surgeon must be your customer. So surgeon has to be convinced definitely that regional anesthesia has its own benefits. So this, as you mentioned that you can begin with the simpler blocks, show the surgeon its benefit, document to the patient that the patient is getting discharged faster. The word of mouth publicity will spread by itself, and then I am sure the utilization will spread and increase as you go on and as you gain experience and expertise, definitely. And another thing which I would like to add here is that I think you should also document your blocks and keep a data. You can then, a very good idea would be in future that you can say that I have given 100 such blocks, and out of which there was no complication or one minor complication, and all the blocks were successful, patient were discharged faster. So instead of quoting the literature data which may not be relevant to your own setup, I think it will be a good idea to keep your own data. If any other panelist has anything to contribute to this, you are welcome to give your comment. Okay, I think we can move to the next question. I would like to ask Dr. Nidhi Bhatia, how much the role is there of the infrastructure and facilities in establishing a dedicated regional anesthesia practices, and do we need an advanced tertiary care setup all the time for practicing regional anesthesia successfully? Dr. Nidhi would be the right person to answer because she is in a tertiary care setup. So, can you please take up this question?
Yeah, sure. Thank you, Dr. Anju. Actually, the infrastructure, am I audible?
Yes, yes, you are very much audible.
So the infrastructure that we need for giving peripheral blocks the basic infrastructure would be same like for any other general anesthetic. That is what we require for a regional anesthetic. It is nothing too elaborate or too advanced. The basic equipment which is required for regional anesthesia services is very simple, and it is less expensive as compared to most of the general anesthetics that we use. And given the setup in the peripheries or in resource limited areas, like the previous speakers, Dr. Ajay and Dr. Maniruzan also mentioned, in peripheries where your advanced equipment is limited, backup is limited, maybe your training is not as much. In those setups, actually, it is more advantageous to be well trained in peripheral nerve blocks and in regional anesthetic techniques, and it comes in quite handy. So the basic equipment which we require is not too advanced, and it is not something that you would want only to be done in a tertiary care setup. So it can very well be taken up in peripheral areas. If the standard monitoring also is very basic, there was this recent monitoring standards article which was published in 2021, which also mentioned, it was published in Anesthesia, which mentioned for peripheral nerve blocks, what you basically need for monitoring is just a non-invasive BP, heart rate, and a saturation. So you don't need advanced monitoring techniques for when you're giving your regional blocks. So having said that, again, you do not require tertiary centers or advanced equipment. for these blocks. What is important is the mindset. Like it was mentioned by Dr. Ajay, we need to bring about a cultural change and remove these misconceptions, especially amongst our surgical colleagues, that regional anesthesia is time consuming, it is not very effective. That mindset needs to be changed, and we need to be more trained in regional anesthesia. So that is more important rather than having some advanced equipment. If we have the availability of ultrasound and nerve stimulators, that adds to the quality of the blocks that you give. It is not a prerequisite for most of your simple blocks, which can also be done by anatomically guided landmark technique. But like previously mentioned, most ultrasound machines now are there available at the bedside, and it is also available with our surgical colleagues, which can be used. So they can come in handy. So that is important. Changing the mindset is more important rather than the advanced infrastructure, which is not needed actually.
May I add something, madam? If you allow.
Sure, Dr. Manu. Please go ahead.
For changing this mindset, what is most important, since all these healthcare setup owners, they all are businessmen, you need to talk to them in their business-oriented manner. Just let me give you one small example. Initially, when I started my practice, most of these nursing homes, they had this Boyle's apparatus, where we used to have this vein circuit for giving general anesthesia, where you have to put in like 6 liters of nitrous oxide and 3 liters of oxygen. So the gas consumption used to be 9 liters per minute. So one day I sat with one of the owners of the nursing home and I told them, see, if you have a proper workstation, your gas consumption will come down to barely 2 liters per minute. So you are cutting on 7 liters of gases per minute. So in the case of 2 hours surgery, you just imagine how much gases you are going to save. Because you are going to charge same from the patient, but you are saving so much on the gas. So how much profit can you make out of a one workstation if you purchase from me? He did all the calculation, and you won't imagine, like within the next 3 months period, he purchased one workstation for the nursing. Like this, there are a lot of studies there. I was just going through one study. Rushali Ponde madam from Odisha, I think she had a paper where she proved that this USG machine, use of USG machine gives you a lot of cost cutting if you are using instead of general anesthesia. So if you talk to them in this commercial manner, they will understand better, I think.
Yes, I would like to add to the point that Sir made about the ultrasound machine. So we have to bring forth this change, that ultrasound machine is not just for giving regional blocks. If you're procuring an ultrasound machine, besides regional block, it can be used for so many other things, for the perioperative care, for diagnosing certain things at the bedside, for so many clinical decision making. And all this should be taken into consideration when we are taking cost of a particular equipment into concern. So there's so many other things.
Definitely, I fully agree with the points made by Dr. Nidhi and Dr. Manirazaman. I think the message here is that first of all, the non-availability of advanced equipment should not be a deterrent or an excuse not to practice regional anesthesia. And all our patients, they deserve the benefits which are imparted by the use of regional anesthesia. So we all should be having this mindset and the motivation to use it. That is the most important rather than advanced equipment. There are many blocks which have similar safety and similar success when they are practiced even with anatomy guided, if they are practiced, and nerve stimulator guided. There is a lot of literature that they provide similar safety and success. But however, obviously we cannot deny that ultrasound provides many benefits, and nowadays I am sure it is not a big thing to convince the surgeon, even if you talk about revenues. As Dr. Manirazaman mentioned, that there is a study also which says that it saves some cost, it leads to cost cutting ultimately, because the dose is reduced, the dose of local anesthetic is reduced, the recovery is faster, and then you have a more short blocks. So I think ultimately it can lead to cost saving. We need more literature on that, but I do agree with the points made by the panelists. Message here is that definitely we should increase the utilization, whichever way it is possible, whether it is anatomically guided, whether it is PNS guided, but we should have the mindset. And training definitely is again very important. It is again and again being highlighted that well-trained anesthesiologist will definitely go a long way in improving the safety. So now my next question would be to Dr. Bijoy Chaithan. The question is that how do you think that regional anesthesia, if it is utilized, it can improve upon the patient safety? Dr. Bijoy, can you please take up?
Yeah, Dr. Anju, thank you. See, basically, most of you all have already mentioned many of the advantages, and we can see that either whether there's no question of when you in 99% of patients, first of all, the airway, you don't need to intubate, extubate. There's no chance for aspiration. There is no PONV. There is no required for mobilization, extra mobilization. The patient can eat early, drink water early. There is a genuine attenuation of a stress response. There is opioid sparing. And in all, there is a shorter hospital stay. In the next 5 years, and without proper using of an ultrasound, there cannot be anesthesia practice. For everything we do, it is no longer you can go blind and injure a nerve. You can go blind and put a central line somewhere else or cause a pneumothorax. So generally, in the next 5 years with handheld missions and with hopefully a easier PNDT Act, or in the case of Tamil Nadu, where Dr. Meenakshi Sundaram as the Director of Medical Services has made 15 days compulsory rotation during the PG period in radio diagnosis as a part of the training program. So that is a part of the Tamil Nadu anesthesia PG training program. So these things, without doubt, I believe that there is a great role to play for regional anesthesia, especially ultrasound and guided blocks. The risk profile of patients has also changed. The ASA grading has changed. The sugar values, they are treating high-risk infections, giving a personal regional anesthesia vis-a-vis a thoracic epidural. When every intervention we do these days, ultrasound is definitely a must. And from opioid sparing to an shorter hospital stay through the airway, and in whatever, there is immense amount of advantage. And when we were giving blind blocks, we were almost using 4 to 5 times the concentration of drugs for a local anesthetic block. So, but those things have changed. Even pain in the, so we've had Dr. Unni Krishnan from Kerala who was giving a block to an auto driver's hand who was during a road traffic accident to release the hand, to release the spasm there. In the emergency, as soon as patient comes in with severe pain, on block with catheters, erector spinae, so many different for multiple rib fractures. So in every phase there is a definite advantage, and as ultrasound machines become cheaper, as some of the comments have put in, there is a definite advantage, and I believe all hospitals, all anesthetists should try to utilize that advantage in the next few years. Thank you, Dr. Anju.
Thank you so much, Dr. Bijoy. Very well said. So the message here is that it definitely improves the patient safety, and I don't think that there is any cost which is more for improving the patient safety. When it comes to patient safety, I don't think we should ever compromise on anything which can improve the patient safety in future. And also there are studies that regional anesthesia, if it is utilized, it does not increase the overall cost. And in low to middle income country, there are multiple studies which show that the safety was more when regional anesthesia was utilized as compared to general anesthesia. So there is no denying this fact. Thank you very much, sir.
May I add?
Yeah, sure. Who is it?
In Maharashtra, the PCPNDT Act is going to remain for at least.
Dr. Shilpa, that is our next question. So it will be addressed in the next question. So can I ask Dr. Manizuraman again? What are the common techniques which can be safely practiced in the private setups? There are multiple, there are innumerable techniques which have been described nowadays in the literature. But not everything we can recommend for very peripheral setups with limited infrastructure. So what in your opinion are the blocks which are commonly practiced and which you think are safe for peripheral setup?
Madam, if you have a PNS machine or USG machine with you, then there is no issue. But even if you don't have a PNS machine or USG machine, there are a huge number of blocks which can easily be performed. Most of these blocks are superficial blocks. You should remember that deeper blocks are little risky, but all the superficial block can be easily given, even blindly. See, this I know a lot of hair transplant centers. Okay, where surgeons, they don't call anesthesiologists. Okay, but they themselves, they are giving supratrochlear, supraorbital block. They are giving scalp block by themselves. Catastrophe do happen at times. That also happens in our OT also. But still, like they are giving it on a regular basis. So if you start right from your head, so you can start with supratrochlear, supraorbital block. We have seen ENT surgeons, they are giving like all the blocks for the ENT procedure in the ear, all the greater auricular temporal nerve block they are giving. These all are superficial block. If you come down, the most widely practiced block, I must say, is brachial plexus block. Supraclavicular brachial plexus block, like we have learned in our college days, in blind technique only. So the supraclavicular block and axillary nerve block, they are very useful and very robust block, I must say. To go below, lip anesthetics, I'm forgetting infraorbital nerve block for lip repair, which is also maybe for post-op analgesia only. Even in adults, we do lip lip repair with infraorbital nerve block only. We don't give PA even. To come down, you do have in your hand, we regularly give wrist block, we regularly give digital nerve block very safely. You will not find any complications. We go below, in the abdomen, we do, like in high risk cases, in hernia, we do triple nerve block, healing hypogastric nerve block. In the hydrocele surgeries, in total surgeries, we give healing hypogastric nerve block. Very frequently we give penile block in case of circumcision. One of the most frequently performed block. Then, even if you go in abdomen also, after this segmental spinal anesthesia have come up, people are doing gallbladder, lap cholecystectomy, appendix, cesarean section, everything. Sections are otherwise also done on neurological block only, but they are doing lap chole and all so many hernias, everything. Ventral hernias also under this segmental anesthesia, which is also a kind of regional anesthesia, you must say. Then if you go below LFCN block, lateral femoral cutaneous nerve block, even femoral nerve block, that is also superficial. We regularly give obturator nerve block in case of TORBT. So that is also we frequently perform rather safely. Sciatic and femoral, we combine them together at times for high risk patients, which is also a superficial block that can also be used very safely. And if you go below, ankle block, digital nerve block. So if you look at a whole body, the ambit is great. Like everywhere in the body these days, you can have some sort of regional anesthesia which can be performed safely. In the superficial, the safety margin is very high. But if it is deeper, you got to be very careful. In those cases, it's better to use either USG machine or PNS or combination of both.
Thank you very much, Dr. Manirazam. Very well said, and you are absolutely right that there are multiple blocks which can be safely performed who have a very good safety profile, like ankle block, and they have a very high rate of success, which have been performed landmark guided and are till date they are being performed landmark guided. So, but the key here is the expertise and experience and the awareness that the blocks are there and they can cover the analgesia, and even surgery can be performed. So basically the main thing which remains here is that the practitioner should have the motivation as well as the training to utilize these blocks. Another thing which I would like to add here is that even local infiltration analgesia, if you are not able to practice somehow, you don't have ultrasound or something, and still we can give the patient the benefit of post-operative analgesia if the surgery is being performed under spinal anesthesia, like knee surgery, like hip surgery. Even the prospect guideline, they have found a very high quality evidence for local infiltration analgesia performed by the surgeon. But the main thing is that we need to be aware of it and we need to encourage these kind of blocks. But the patient should ultimately be the beneficiary. So thank you very much. Now I would like to ask Dr. Ashit Mehta if you can take up this question. Do we really need ultrasound for all the nerve blocks? We have partly answered this, but still we can have a debate on this. What are the barriers of acquisition of the ultrasound machine? And if ultrasound machine is not accessible, what are the safe alternatives to regional anesthesia practice in peripheral setups?
Yes. Okay. Am I audible?
Yes, sir. You are perfectly audible.
Yes. Your first question is, do we really need ultrasound for all nerve blocks? I have some different opinion about it. That I'm practicing regional anesthesia from last 20 years. Instead of depending on the hospitals, I have purchased a machine of my own. The reason behind is that I get my machine when I want it, because when we need the machine, the machine is always engaged in the hospital to some other reasons, like doing ultrasound or echo. So we don't get it at the time when we want it. So we always lack in learning that process of using ultrasound. And as everybody has mentioned about the ultrasound machine, it has a specific advantage, like we can avoid trauma to vital structures like vessels, the pleura. We can avoid intraneural injections because we can actually see the structures on ultrasound. But as you asked whether it is compulsory to use ultrasound machine, the answer is no, because we have an alternative of peripheral nerve stimulators. Now your second question was about the ultrasound machine barriers. Yes, there are barriers, but I have done it. We have to take the certificate from PCPNDT, and we can keep the records. It's not a very big issue. We can easily do it, but the main problem with the barrier is that the machines are a bit costly. We have to maintain them. Second is, I have mentioned earlier that there is a PCPNDT Act. Third is, even if you have a letter from PCPNDT or you have a certificate that you can use the ultrasound machine, the thing is that you cannot carry your machine to each and every center where you are practicing. So you have to keep your machine in only one center. That is the main disadvantage. But believe me, if we start using ultrasound machine, it becomes, you are become very confident, and we will be able to give different nerve blocks very easily.
Thank you, sir.
The third question was if the ultrasound machine is not accessible. Yes, while learning the techniques, we have to first go on step by step. We have to first learn the PNS techniques and then go to the ultrasound machine. So even if there is a failure of the ultrasound machine, of its unavailability, we can always use this PNS machine and give the block equally good and of the same quality and of the same safety. But we have to always remember that even with these gadgets, these are not the substitute for the knowledge of the anatomy.
Definitely. I fully agree. So basically it depends on the provider comfort. The provider should be comfortable in giving a block, and then only should have a sound knowledge in the anatomy and pharmacology.
These gadgets are not the substitute
Definitely.
for this anatomy.
Even ultrasound is not a substitute for a sound knowledge of anatomy. In fact, we have to have a knowledge of anatomy as well as sonoanatomy. With ultrasound, we need to have the knowledge. So, yes, and I think in future we are hopeful of getting the pocket ultrasounds like they are available now in the foreign countries. Only barrier being the PCPNDT Act. So probably hopefully in future if the rules are relaxed, we will have our own pocket ultrasound, and we can connect it to our smartphones or laptops, and we can definitely practice, and that will be a boon to the private practitioners definitely. Because right now, as you mentioned, that this portability is definitely one issue. Portability is also one issue, because big ultrasound machines are generally stationed in one setup, but they cannot be carried into the other setup. So that is another issue, portability. And in that aspect, PNS scores over ultrasound,
Yes, yes.
because it is a very portable thing and very, very less expensive, and it can be carried to other areas.
Yes, and equally competent.
And equally competent. Definitely, till now the block success, hardly it has been proven. In most of the studies it has been found to be equivalent. Okay.
Can I ask something? If
Yes.
yeah, like Dr. Ashit sir mentioned, they have their own ultrasound machine, and if we have a portable machine also, if we decide to move it from one center to another, is it allowed under PCPNDT?
No,
Or
no,
do
no,
we-
it's not allowed at all.
Yeah.
But the thing is that the center where I work, I always have adequate work at a one center only. So it's my, I mean, I have got that opportunity to work in one center where I have to perform the blocks. In other center, I go at about 2 o'clock in the afternoon. So most of the chunk of my work is only one hospital. So I keep that machine in only one hospital.
Another thing which I would like to mention here is that nowadays even court hearings, if all of you must be aware of the case where the supraclavicular line, subclavian line, it was inserted, landmark guided, and the patient landed into a complication, and even Supreme Court ruling said that why ultrasound was not used. So these kind of legal litigations are also bound to come. We are bound to face these kind of litigations in future, and I think it will be very easy for us to convince to the authorities to procure a ultrasound machine, considering that it is not only regional anesthesia, it is also important for mandatory procedures like central line, where the safety is definitely 100% better. Sorry. So my next okay, so Dr. Nidhi, can you take up the next question, please? So do you think that the regional anesthesia is more cost effective as compared to general anesthesia in terms of the additional time which is needed to perform the block? So surgeons are always blaming us that you are wasting our OT time. So do you think that it is more cost effective in terms of recovery time, home readiness, hospital stay, complications? And more importantly, what is the role of regional anesthesia in ERAS, considering that in all the kind of surgeries, the ERAS is coming up in a big way?
Yeah. So currently, ERAS has really come up in a big way, and regional anesthesia, I feel, is definitely more cost effective. Like when we talk about hospital costs, there could be the cost involves your intraoperative costs as well as your immediate post-operative and the cost during your hospital stay, if we divide it like that. Now, intraoperatively, when we are using regional anesthesia, as compared to general anesthesia, you're decreasing a number of life-threatening airway or respiratory complications. You're decreasing the OT time in that fashion. Then there is this constant complaint, like you also mentioned, that the blocks may take longer. But when you start practicing regional anesthesia, most of the blocks don't take that long. And if you have the facility, or if maybe your footfall in the OT is more, and if the facility is there, you can use a block room if available. Yeah, or a pre-induction room, because you don't need too much of monitoring there, and you can give a block there while cases previously going on in the OT. So that can be done to reduce the OT time. But I always feel if you have given a block and your patient is being done under that, you are saving the time of extubation and emergency. That time also you need to consider when you're giving general anesthetic. So your overall operational time actually does not increase that much as much it is made out to be by, the surgeons especially, because that is what they feel, that it wastes a lot of OT time. So these are the techniques which can be done to decrease your operational time. Then secondly, once you are getting a patient done under regional anesthesia, especially if the patient is awake, you do not need stringent PACU stay for the patient. So your post-anesthesia care unit stay is not as stringent as is in the case of patients who undergo general anesthesia. So that time is saved. Thirdly, your readiness to discharge is increased because your post-op complications are less. Effective pain management with regional anesthesia decreases the use of opioids, And as a result of that, there is decreased side effects of opioids like nausea, vomiting, sedation. All this is decreased. Your enteral nutrition, your oral nutrition can begin early. The patient is up and about early. So your recovery time is shortened and your functional recovery is quicker. So all of these greatly decrease the costs, the hospital costs. Additionally, the equipment required for giving blocks is very simple. You save on so many drugs, so many syringes. There's so many additional costs which come in, which are there, when you're giving a general anesthetic. So all that is in addition saved. So all this, it generally enhances your recovery post-surgery. So this forms a very, very important component of ERAS. All of these factors, they greatly enhance recovery and reduce your cost. Yeah,
Absolutely,
very cost effective.
I fully agree that it is an essential component of ERAS pathway. And since you mentioned that the discharge readiness is improved, that is of great benefit for centers which are daycare centers. And I think peripheral setups, most of the patient would prefer to go back home, and many centers are actually daycare centers only. And I think in cost saving, it has been proven by evidence that regional anesthesia use, it is more cost effective. In some of the literature, it has been proven that the cost was in fact much less. Also, it decreases the length of stay. So hospital cost is also decreased, and overall patient costs are also decreased.
Yeah. And when you see the patient's safety and the benefit it gives to the patient, I think cost actually becomes very secondary in that sense.
Yeah, morbidity benefit.
May I add something, madam? May
Yes.
I add something?
Yes.
It's not only cost. Yesterday I was driving to hospital. I was listening to the radio. There's one some Dr. Suryoday Singh is an orthopedic surgeon. Come to him for TKR surgery. He make you stand on same day. In the morning you get surgery. In the evening you start walking. Now who's doing all this? This is just because of a very, very good block given by anesthesiologist. So, and in a center where I work there, every day we do 15 to 20 TKR surgeries. And in our setup, surgeons, they encourage us to give good blocks. Okay, so it's not only like for our patients' benefit and our benefit and cost benefit ratio, it helps them, surgeons also, to market themselves. Once they see that in our center, we hardly take 5 to 6 minutes time to give adductor canal or femoral nerve block. So they see once you start giving the same block regularly, again and again, so this block timing comes down drastically. So, and that helps their marketing as well. So,
Definitely.
So
I fully endorse your views. So basically, it is the high time that the surgeon need to be aware of the benefits, and they themselves should endorse it to their patient when they present to their clinics, that you can get this benefit of this regional block, which are very well practiced in our setup. So in fact, Dr. Hedzik, who is a big shot in regional anesthesia, he himself underwent a big shoulder surgery, and he received a regional anesthesia block, obviously, and the same day he went to a mall with his family. So he was mentioning this incidents. So this is the kind of discharge readiness which it offers, because the opioid use is minimal to zero. So that is the benefit which we all are talking about.
And I can, if I may add, if you are using peripheral block catheters, I mean, it may not be feasible in all situations or in all setups, but like I'm just sharing the experience, what we are practicing, we've started practicing, like in upper limb, like patients on arrival with crush injuries of the hand, we place in infraclavicular catheters at the site of arrival, like as soon as they come to the emergency. So those catheters before surgery, they help in the immense pain which is there. It helps in pain relief and your radiological evaluation of the limb. Plus, when the patients are shifted for surgery, through those catheters, we give the anesthetic dose in the pre-induction room itself, and the patient is shifted for surgery. And so everything is very smooth, and it actually decreases your OT time. So it can be used where feasible. So it really adds, and it actually decreases OT time rather than increasing it.
Yes.
So
Well,
that we found useful.
Definitely, that is another area which is where regional anesthesia is coming up in a big way, and it has definite role. So now my next question is for Dr. Ajay Hegde. Which sedative agents do you think are preferred in peripheral setups, And what local anesthetic and adjuvants are utilized when you are giving your nerve blocks in your peripheral setups?
For me, it's mainly the benzodiazepines like either midazolam or diazepam, which is mainly used for the sedative and anxiolytic purposes in perioperative period. And in some more anxious people, for who are feared of needle sticks, I usually use midazolam in a pre-block to sedate them, and then under sedation we'll be giving the nerve block. And another intraoperatively commonly used is either propofol infusion or dexmedetomidine infusion, which we regularly use.
So, Dr. J, if I can interrupt you, you mentioned that you are using diazepam also. So, don't you think that it will prolong the patient's recovery and the benefit of the regional anesthesia may be negated?
Where the midazolam is not available, sometimes we will be using diazepam.
So, basically, it is the cost concern. But do you think that dexmedetomidine is also very expensive? So, is it freely available in your setup?
No, in my setup, I have bought the dexmedetomidine. So I have convinced the management that I need that drug for the ICU sedation and everything. So I was able to get the dexmedetomidine. So I am using the dexmedetomidine both for the sedative purposes as well as sometimes even as an adjuvant. Also, I will be using the dexmedetomidine, especially in diabetic patients where commonly the used adjuvant. I use the dexamethasone, but in diabetic patients where there's fear of the chance of having the perioperative hyperglycemia with the dexamethasone, in those patients I will be using dexmedetomidine as an adjuvant.
Okay, very nice. So, but what about ketamine? Ketamine is one very favored drug among the private practitioners. So, are you not using it?
I'm using it very sparingly.
Why? What is the reason?
Mainly the postoperative period, they will have a lot of irritation and all those things. So the attenders are not very comfortable when the patient comes out of the OT with ketamine effect. So, yeah, sometimes they will be aggressive, sometimes they will be in a singing mode, happy mode. That the mood shifts. I've seen a lot of changes are there. So many families don't like the ketamine in the So even when I'm using, I'll be using under the coverage of midazolam.
Okay. So well said. But otherwise, other panelists, do you have to have other preference regarding the sedatives? Nowadays, Ketodex is in a great vogue nowadays. It is gaining a lot of popularity for regional anesthesia as a sedative. Can any panelist share their experiences regarding the use of Ketodex? Anyone who has used it? So personally, I have used it. Okay, Dr. Mani.
I have also used
yes, Dr. Manizuram.
Today itself, I used it. Today itself, I used it.
Loudly. Your voice is not clear. Please, can you speak loudly?
Can you hear me now?
Yes, better.
So what is your experience? Very useful and very handy thing. Like today itself, we use in like the one ENT surgery was going on, tympanoplasty, and the surgeon they asked to sedate the patient. We started one infusion of Dexcate, like you are saying Ketodex, we call it Dexcate. So Dex 100 microgram of dexmedetomidine with 100 milligram of ketamine. We just charged in an IV bottle, and then we started the infusion in a rate so that it gets over in 2 hours time. So gradually, initially, you may need to add some propofol sort of thing to just put the patient into sedation, and once that infusion takes over, it's fantastic. Patient doesn't move at all. It's a very good sedative and analgesic as well.
Yes.
So patient
Thank you for sharing your experience. Yes, so definitely it adds to the benefits and while contradicting the disadvantages or adverse effects like emergence, delirium and all. So with our increasing knowledge and availability of the drugs, we can counter the side effects of the available or of the older sedative agents which were not being used so frequently. Which were used earlier, and now we have additional drugs and so many options which are available. Who is it? Can we move to the next question? Somebody, Dr. Sadab, can you please mute your mic? Dr. Sadab? Okay. So my next question is for Dr. Shilpa Tivaskar. Can you answer this question that should we be prepared for general anesthesia in every case which is being done under regional anesthesia? And also there can be a situation or scenario where the patient has a difficult airway and we are practicing regional anesthesia. So what is the specific consideration in such kind of a patient for private setup?
Yeah, thank you, madam. Regarding your first question, as I always believe, we always talk about peripheral setup, compromised condition. But personally, I feel the anesthesiologist is the one who makes the conditions compromise. If he keeps a proper circuit, proper oxygen, proper all instruments ready, why should the peripheral setup be also compromised, right? And also regarding general anesthesia things ready, of course it should be ready. Like if I'm giving a lumbar plexus block, I gave 10 lumbar plexus block, the 11th one went high epidural. So epidural sleeve was there. While giving interscalene block, you can still have injection in subarachnoid space, how much ever you are doing, or you can have a phrenic block. So everything should be kept ready for general anesthesia. Now this is regarding the block, but there, like in obese patient, if you see under sonography also, when you are giving block because of the high respiratory rate, it's very difficult to see the needle. So even if you are giving PNS guided because of short neck, the fat, and hence your block may be inadequate. It's not your skill. It just may be inadequate because of the patient factor, obesity, or maybe ankylosing spondylosis. So all these patient factors, or the surgery could be prolonged, suddenly unexpected complication can occur. There could be blood loss. So it should not that you don't have anything ready for general anesthesia. Everything should be ready. And secondly, you asked about difficult airway, whether we should give regional anesthesia. See, at present, I work in a corporate-like setup, but still we prefer to give regional anesthesia even in a patient with difficult airway. But there are some conditions like I'll be giving regional anesthesia.
Increase the volume. Shilpa ma'am?
Yeah.
Can you please increase the volume?
Increase? Oh, sorry. I thought I was speaking loudly. So
No. Thank you, ma'am.
Is it okay?
Yes, ma'am, better.
Yeah. Sorry.
No,
Yeah.
that's okay.
Yeah. So in my setup also, I will give regional anesthesia, but I'll do patient selection. Like if it's a difficult airway and I have to do prone position, suppose I'm doing a single disc and I want to give regional, but I would use in a difficult airway. Or if I'm expecting a blood loss more than 500, or if there are any fluid shifts, or if there are any patient conditions, patient is asthmatic, and this, so it's better that I choose my patient. I choose the duration of surgery. I choose the blood loss if it's there, major fluid shifts. So mostly suppose I'm doing a urological or orthopedic surgery, then I should be supplementing with epidural beforehand, expecting that the surgery may get prolonged.
Okay. Very well said. To sum up, basically we should be ready to deal with any complication of regional anesthesia which may occur. So we have to be ready with general anesthesia as well as all resuscitative equipments whenever and wherever we are practicing regional anesthesia, because overall it is only the safety which is the most important, and we have to be ready with all the backup. And then difficult airway, you very rightly said that we have to select our patients where we can practice, and in additional we should always be ready with the management of airway in such a case where we are practicing regional anesthesia in such a case, because as somebody said that the difficult airway, in a case of regional anesthesia for a difficult airway, the difficult airway has not gone anywhere. It is there in front of us, it remains, and anytime we may need to deal with the airway. The airway still remains one of the, it is not gone anywhere, and we still need to be ready with dealing with any kind of complication and as well as securing the airway all the time. We should be ready with all the backup. So now my next question is to Dr. Bijoy Chetrat. What are the specific considerations of performing regional anesthesia in peripheral setups in patients who are presenting to us with comorbidities? Because nowadays the patient expectancy, the life expectancy as it is increasing, and peripheral setups, they are taking up more and more complicated surgeries. So now these kind of things, scenarios will come to us inevitably. So we need to be prepared with these kind of scenarios. So first scenario would be like a patient who has a diabetes mellitus with autonomic neuropathy. So what do you think will be the considerations, and what can be the legal implications also of practicing regional anesthesia in such case?
Yeah, Dr. Anju and all this is a very technical question in the sense that diabetes mellitus in patients who have autonomic neuropathy is a different picture. First, if you're using a nerve stimulator to block a nerve, generally you expect to get a stimulus between 0.4 or 0.5, 0.6 milliamperes. In patients who have severe diabetic neuropathy, this may go up to 1 milliampere or more. That is significant. So what you anticipate itself from a peripheral nerve stimulator, and actually when you're reaching too close at 0.4 or 0.5, you're probably causing a damage to the nerve. Secondly, in diabetic neuropathy, autonomic neuropathy, the local anesthetic sensitivity of the local anesthetic dose is much higher. So you get a 50 to 100% more faster onset of the block. And not only does the onset of the block is not just that it is faster, the duration of also is longer. So what happens is that pressure source or a patient prolonged. So you as an anesthetist, you expected the patient to come out in 3 or 4 hours or even 6 to 12 hours. But in some patients, the block lasts for 24 hours or more, causing tremendous amount of distress. That could be because of a diabetic autonomic neuropathy in that. Then again, there is a metabolic injury to the nerve there. So when there is a metabolic injury to the nerve, what the local anesthetic does is that you must remember that all local anesthetics are primarily neurotoxic, as it is. So when there is a metabolic injury to the drug, to the nerve, what a local anesthetic does is that it increases significantly the neural toxicity at the nerve end. So that may be around 0.4% vis-a-vis a regular point, or 0.4. There's almost a 40% more chance for a neural toxicity to the nerve. So that those things also have to be kept in mind when considering a diabetic patient. So you have to use lower volumes. You may expect a faster onset. You must, I think all this is from a diabetic patient with autonomic neuropathy. Not all patients who are diabetic have autonomic neuropathy, but the question per se is about autonomic neuropathy. So there is damage to the nerves already. So local can worsen that. There is a metabolic imbalance already. The PNS will not act, and what you expect may be causing further damage when using a peripheral nerve stimulator. And again, the duration of action. So when you give a patient a block who is diabetic, it is important to convince them, yeah, boss, we have not 4 to 6 hours. You can expect the drug to last much longer. So these things have to be kept in mind when. So already I have mentioned the advantages of using the no intubation, no chance of aspiration, PONV. All that is the advantages. The disadvantages in a diabetic whose autonomic neuropathy is like that. So again, those things have to be borne in mind. That is my opinion. So please, whoever is giving a block, be aware of diabetic autonomic neuropathy, especially as we use it for so many procedures of diabetic foot and all that these days. So these things have to be kept in mind. The consent has to involve that there could be a prolonged duration of the block. When talking to the patient or the bystanders, that needs to be put across that, yeah, the block may act longer. So please bear with us. That once the block's duration stops, the pain will start. So it is okay to have a prolonged block and is a life-saving procedure. Keep that in mind. So thank you. So that is about diabetic neuropathy. That's it. And suppose so we've already, Dr. Shilpa was speaking about in morbidly obese patients, the difficulty in accessing these spaces, the difficulty in placing a needle adequately. All those things have, and the volume of drug which we give vis-a-vis. So, and the necessity for all sorts of safety measures, including intralipid in all the hospitals where blocks are given. Maybe we are using far lesser concentrations, far lesser volumes vis-a-vis what was done under blind blocks earlier. But safety, there is no excuse to do some blocks without safety. That is the underlying fact. Okay,
Excellent sum up, Dr. Bijoy, regarding the considerations of diabetes mellitus especially. I think ischemic neuropathy is always a risk in such cases. And as you mentioned, communication is a key. We need to communicate the additional risk in such cases to the patient and take the patient in loop while taking the decision, as well as the surgeon also in the loop if we are taking a decision for regional anesthesia. And also one thing, if the patient is adamant about not receiving regional anesthesia, we should never force the patient. That is another thing. We should lay down all the benefits as well as the harms, and we should be honest about the harms also. It should not be our decision, it should be a mutual decision. So very well said. And regarding the obese patient, I think one consideration in peripheral setup can be, because the patients would not like to have multiple pricks. So we need to, I think, tell the patient also that since the body weight is such that you might receive some more number of needle pricks as compared to normal patient. What do you think about it? Should we inform the patient rather than later on facing any kind of litigation that you gave multiple pricks to me and I had so much of discomfort, and later on maybe some backache or something may be blamed on us?
Generally, I treat backache per se, and backache due to a needle prick is generally more 90% L4, L5, L5, S1 level. So all regional anesthesia, generally we L2, L3, L3, L4 for a spinal or whatever it is. So generally, backache as such as caused due to a needle injury is a misnomer. So generally, you're able to convince people that, no, this is what we are doing. I use needles to treat the pain actually, and this is not very, very unlikely that in any scenario that a needle causes back pain per se. The positioning of the patient, prolonged duration of the surgery, and irresponsible. And again, the idea of sedation was earlier mentioned. So suppose we use a mixture with midazolam and dexmedetomidine. So we hardly give 5 to 10 microgram of dexmedetomidine and 1 to 2 milligrams of midazolam per patient. And generally, when you insert a needle for a block, you give a local of around 1 ml as a local subcutaneously, so that further manipulations of the needle will not cause a sensory stimulation equivalent to just pulling out and keeping on reintroducing the needle. So giving 1 ml subcutaneously will, to some extent, and adequate sedation will take care of the idea of multiple needles, which are very often required for a proper block.
Yeah. So basically maintaining patient comfort, anticipating such kind of things, and trying to give the patient as much comfort as possible, and maintaining close contact. That is all very important in such kind of things. So can anyone, would anyone like to take up this scenario where the patient is on anticoagulants and we are contemplating on regional anesthesia in such a patient? What would be the specific considerations in such a case?
Patients on anticoagulant, we should, whenever we have a patient, we can perform all the blocks which are very superficial, like a supraclavicular block or an axillary block or a femoral block. where we use ultrasound and we avoid breaking the vessels. So it can be very safely practiced even in patients with anticoagulant. But we have to always take care while giving deep blocks like a sauce compartment block or a patient with a parasacral approach sciatic nerve block, where we should be very careful while using these blocks with anticoagulant. But the superficial block can be very easily managed even if they are under anticoagulants.
I'd like to add to what Dr. Ashit said.
Yes,
See, generally, what we regard as with after clopidogrel 5 days. See, what people for a postgraduate student who's listening to this panel, yes, that is the answer. That is true. For those who are practicing anesthesia on a regular basis, it is assumed that within 3 days, platelet function returns to around 50% of 50% normal, and that is enough to plug this thing. See, and again, when you're using an inline technique, and almost inevitably you have a van wherein the nerve lies close to an artery. If you're using an inline technique and you're using a lateral approach, and you ensure that the drug is deposited preferably lateral to the nerve, you can don't come out of plane, come in plane and deposit the drug lateral to the nerve. The chances of a vascular injury are less. And any day, a vascular injury in the periphery, vis-a-vis a hematoma, there can be managed by pressure alone, most often, rather than for using a subarachnoid block, the spinal or an epidural. Any day you have to evaluate the risk versus benefit ratio. You can't put a patient who is 85 years old with a femur fracture or something which can be done under block adequately. You can't put the patient at risk and ask him to wait 7 days for the surgery just because he is taking clopidogrel. That is life-threatening. So in my opinion, you evaluate on a person-to-person basis, see what can be done, do your routine investigation, PTINR, BTCT, and try to get an adequate consent. In that consent, you should mention the possibility of an hematoma formation, and you should mention that, yes, we are doing this because we believe the benefit outweighs the risk. Once that consent is underdone under paper, we can proceed with a regional block in spite of the patient being on anticoagulants. For a PG perspective, yes, you need to wait for the 5 days or 7 days when the question is asked in the paper. That is the idea. So please, every day we have changing standards. We have a gross elderly population, people coming to us 90, 95 for surgeries, and you leave them on for 2 or 3 days, their prognosis is much, much worse. So considering and evaluating on a person-to-person basis and getting a proper, well-written, well-explained consent will generally take care of it. That's my opinion. Thank you.
Yes, Dr. Bijoy, I fully agree with you. Individualized approach is the best approach, and the pros and cons should always be weighed, and they should be laid down in front of the patient, and patient should be fully informed. And now, in fact, the literature has come up stopping the clopidogrel for even single day, and regional anesthesia is the literature is coming up on that regard. And especially, I think this is in relation to because we have more and more access to ultrasound, and we can visualize the arteries and veins, and we can avoid them. So this is definitely a feasible approach, and literature will come up, more and more literature will come up on that. So now my next question would be to Dr. Shilpa. Can we now talk about the post-block management? We keep on doing blocks, private practice, the practitioner comes, gives the block, the surgery is over, and the practitioner, goes away. So do you think that it is our responsibility to monitor the patient also post-block? Any kind of complication, if it happens, it is on us. to monitor the patient even after we have given some block. Post-operative pain management, once you have given the block, at some point it will wear off, and if you have not given adequate instructions, do you think that patient satisfaction will go down? And if you are using continuous block, what catheters and regimes do you use? Like if we have inserted some catheter, it should be some written responsibility for person who is going to remove them and manage them. So what is your take on that?
Yeah, so multiple questions. First is you asked the post-block management.
Yeah.
Yeah, so if it is a big surgery, block is given, the patient is admitted, not daycare. So patient is overnight with us. So we tell them that till 24 to 48 hours, the limb can remain numb. So be careful with trauma from either any mechanical trauma or it could be any heat trauma. So also at the end of the procedure, see usually pain management is done after the block by the surgeons. They will start some paracetamol or tramadol. But I think the fracture reduction itself decreases the pain, and our block takes care of it for say 24 to 48 hours, because nowadays most of us add additives to the block, right? And ropivacaine, the S-enantiomer, has also prolonged the duration of the block. Then you asked me regarding, sometimes we give block for a patient with K-wire and the surgeon asks us, madam, see within 24 hours, so suppose I'm doing night case and can he go home tomorrow? So again, same, if it is with K-wire, we tell the surgeon to give some support so that the patient remembers that the hand has to be cared of, and then that support can be removed after 24 hours. And same, care of the limb, not to touch anywhere to anything warm or no trauma. Regarding the catheters, we tried putting catheters in private, but I think for a private practitioner, even epidural catheter has become so much training to the staff. So block catheter may not be feasible. Also, secondly, who is injecting what drug, you asked, right? So I think if you want to keep a block catheter, you need someone round the clock visiting the patient and giving the bolus. Or if you are using a pump, then someone should be continuously monitoring the patient. Yeah, so just keeping a catheter and leaving it, and then you cannot have that. The pain physician, the anesthesiologist should be monitoring personally.
Absolutely, absolutely. So basically the onus is on us. We are practicing regional anesthesia. We should communicate the patient. All the instructions should be very clear, and we should be taking care of whatever we have done. The patient's post-op pain management is also our responsibility, as well as if we have inserted some catheter, that is also our responsibility. So everything should be a protocol within that institute, that who is going to take care of the patient or post-operative pain or the catheters, who will be injecting and who will monitoring the patient. So everything.
Something?
Yes, ma'am.
Like Shitma madam said, in addition to the post-operative pain management, you're telling the patient regarding that the site is blocked and you have to be careful about any damage because of heat or anything. In addition, it is important that we follow some kind of a multimodal analgesic regime, because if you're giving a single shot block, once that block wears off, if you're not careful with your post-operative instructions, immediate breakthrough pain is also a known entity. Patients do have that. So you should have a multimodal analgesia to cover for that. So that is also very important. And if catheters are in place, one important common problem which happens with catheters is the dislodgement of catheters.
Yeah.
So the fixation should be very, very proper. And some centers do practice tunneling of catheters also. So your fixation should be very proper. And before every bolus, always do confirm that the catheter is in proper place in situ if possible, if you are managing catheters.
Yeah, so madam, you are talking about the catheters. I wanted to know, like, see, mostly the adductor canal catheters or the interscaling catheters, right? So do we actually keep them for more than 24 hours? Like, how is at your institute?
We've kept them for 24 hours, the interscaling. I have kept the fascia iliaca catheters for around 48 hours. And we have kept infraclavicular catheters for almost 72 hours also. We put them preoperatively throughout the surgery and post-operatively for 72 hours we have kept. So that is my experience with these 3 catheters. With interscaling fascia iliaca for 48 hours we have kept. We give continuous infusion, then obviously we monitor. And infraclavicular, when we are giving boluses, you should know who is going to give the bolus, the resident who has knowledge about the boluses. Not anyone can just go and give a bolus in a catheter. So that is very important. You have to actually follow up your patients till you remove the catheters properly.
So basically, it is important to follow up what you have done, and the roles and responsibilities should be very clear. Who is going to do and manage and monitor? So everything should be very clear. But the thing is that we are not talking about the tertiary care setups. There are a lot of people who take care of the things. We have people who we can delegate the responsibility. It is about the peripheral setups where a single-handed person who is giving the block also has the onus of monitoring. So how we can improve the safety in such setups if we are using continuous catheters? So any other panelists would like to add here?
Regarding the continuous catheter, one thing I'd very frequently we perform brachial plexus block in these small setups. And very frequently the plastic surgeons, they bring small injuries for which we give this single shot brachial plexus block. But most of the time we forget that and those patients, they go back home very early. After the surgery is over, it was done in a completely awake condition. So it is our duty to ask them to put the hand or arm in the arm pouch properly. Because this is where we mostly do not see this, we do not ask the surgeon also. And I have seen incidents happening. Patient wasn't given arm pouch and he was given the brachial plexus block, and
Yes.
We should keep in mind always while giving a brachial plexus or whichever part of the body, it should be properly supported.
So basically, I think we can sum up because we are lagging behind in time. The thing is that continuous catheters are a big responsibility, and it can definitely be practiced, and patient can even be sent to home with this portable pumps which are available nowadays. But thing is that every instruction should be very clear, and we should be having some kind of backup if such a patient lands into some complication. So things should be very clear. If we are practicing, we should have the expertise and we should have the clear laid down guidelines on its managing of the catheters. So next we move on to the next question, which is for Dr. Ashit Mehta. Can you take up the next question? So what are, sir, your suggestions in increasing the utilization of regional anesthesia in private practice? Right now, we are all aware that it is underutilized and it can definitely improve the patient outcomes, but it remains underutilized. So what are your suggestions regarding that?
Yes, the question is what is my suggestion? So to utilize regional anesthesia in private practice, we have to learn and practice different blocks. To learn and gain the confidence, we have to practice them. We have to attend different workshops. So for that matter, we have formed a society of AORA, that is Academy of Regional Anesthesia of India, where we conduct these conferences every year, and we conduct a lot of workshops. We have courses of 8 days and 1 year courses, fellowship courses, which we should take care of. And one of such center is in Coimbatore, under the guidance of the very efficient personality, Dr. Bala Venkat sir, where the volume of work is very high. We have to go there, see how they give the blocks, master these blocks, practice them at your periphery. When it comes to the cost, the second question is cost. As everybody of us has talked about the cost, the regional anesthesia itself makes it a very low cost. And as we all know, it needs very less monitoring and less gadgets. Thus, we can make these blocks very popular in our places, that is in the periphery as well.
Okay. I think one major variant.
Dr. Anju.
Yes, sir.
Regarding this thing, how the practitioners, putting the practitioners into the mainstream of regional anesthesia, these are not just a workshop. It's basically how the mentality has to be changed to practice regional anesthesia, isn't it?
Definitely.
The learning curves of practitioner is much steeper as compared to the PG students, or even the senior residents of the institutions, if you ask me honestly, we have been seeing these things for a long, long time, that the practitioner learn the things faster. For doing that, ISA has already started the skill centers throughout the India. You can't just have a conference and a workshop and teach the things. You have to have centers throughout India. Nobody wants to walk and travel all the way to Bangalore to learn the things. So here, what we have done at ISA, the entire this one notification has gone to the skill centers of, because it is being practiced in every city. There are certain anesthesiologists who are well versed with one technique or the other. Teach them. You can get a teaching there. You can get a fellowship there if the center qualifies for a fellowship program. So the programs of ISAs are to have identify all the skill centers. The people have to come up. People have to come up to apply for a training in those centers, and everybody can spare 7 days to 10 days for a training as long as they want. From 6 months, every 6 months or every 3 months, they can go to those centers. Those centers have already been, notified by ISA in the coming days. Moreover, the CMEs, the workshops, the conferences, the zonal, the state, everywhere the regional workshops are being conducted. So it's easy for the logistics are very important in learning the things. A practitioner of a Coimbatore cannot travel to the Uttarakhand for to learn the practice if that workshop is held there. Somebody from Borivali going to Jaipur or to the Tripura, it's very difficult. So logistics have to be taken care of. So every center has to be identified in India, and every state has to be identified in India, or every city rather, where you can have dedicated skill centers, having the CMEs, then identifying the skill center, then asking the practitioner to come up. I know the practitioner of our country, when you are earning a bread, you are earning a bread through your practice. The way you learn the things when you are earning a bread is much, much faster and steeper, this one curve. You learn it very fast. You learn it in such a manner that you do it for the safety of patient and safety of yourself. In institutions, you learn the things and you make blunders because you are being covered by somebody senior, somebody else is there, the institutional protection force is there. But in periphery, nobody is going to protect you. So you very well know when a person is on the edge, the learning curve is much, much steeper. So this program is basically meant for that only. The guidelines are also coming into force. From the ISA side, there is an initiative already. The guidelines for the regional anesthesia for Indian guidelines. We have already started working upon that, and that will be formulated very soon. I think those are required now. So we already had 2 sessions on that, the pros and cons for whether we should have Indian guidelines or not. But this message is that the practitioner, without the practitioners participating into the guidelines, research, or the practice or evidence-based practice, we cannot move forward. Institutions cannot take the anesthesia fraternity forward until unless the practitioners also contribute their thing. That is what I want to say.
Absolutely, sir. I think that is a wonderful initiative from ISA, and I think it will go in long way in improving the safety and training of the practitioners. And I think even the state branches, if they can take up this task of making some local guidelines which are suitable to their culture and local setup, and come out with some basic blocks and which are safe, and how to improve the safety of regional anesthesia, I think that will add to.
Cannot do. The directive has to go from the national. ISA national has to give the directive because these things are under control. You cannot formulate guidelines at the state level. These requires a proper, stringent monitoring, stringent grinding of the literature, stringent practices. So many things are there. At the state level, you cannot leave these things. You have to have a national directive from that to involve the state branches. So that is everything is being taken care of while formulating these national guidelines.
Wonderful, sir. So another major barrier in the practice of regional anesthesia is the fear of litigation. Surgeon initially, I think many years back, they used to say that double the anesthetic, double the risk. So why you are increasing the risk to the patient? With general anesthesia, why you need to add another anesthetic, another regional anesthesia also? So what is the take of the panelist on this, that how to decrease this fear of litigation among the private practitioner, so as to improve the utilization also, and how we can go further in improving the safety in peripheral setups. Any other comments or suggestions from the panelists? Apart from the training which has been discussed very well, any other measures which can go a long way in improving the safety and decreasing the fear among the practitioners?
First and foremost is the PNDT Act. Unless
Very true.
if you can actually say that, yeah, anesthetists can practice and use the ultrasound for anesthesia procedures, unless proven otherwise, they have the right to use it. Then itself, training, everything else becomes much more easier. Secondly, we have to bypass the PNDT Act by giving a radio diagnosis posting for all the postgraduate students, making that compulsory in each state. And from the ISA national, there has to be an initiative to make postgraduate radio diagnosis a part of posting in radio diagnosis a part of their PG training. So that itself, that shows that they have been trained in radio diagnosis and they can therefore practice anesthesia in peripheries also by using the ultrasound. So either we have to directly make changes and or request that the PNDT Act be changed, or we have to find ways where we make that anesthesiologists are also receiving training as per the PNDT Act and can use it. So that itself will remove 90% of the hurdles which we face in practicing of regional anesthesia, and will be beneficial for each of us. That is what I think.
I'm sure ISA will do something in this regard and have the
regarding
with us.
Yeah, regarding, see, ISA will take its own measure, but I think the practitioners should continuously be meeting the people who are involved in giving permission. Like for our hospital, we took nearly 1.5 years. We had to give them references. We had to tell them that we had to literally take permission from our radiologist. So instead of asking for permission, we told our radiologist, okay, you take sessions for us. And then when he was scanning the supraclavicular area, he was doing it so fast. So we showed him, see, we can scan slowly also like you. So then he gave us permission. Then we had to convince our CEO that it is actually required for us. It will increase the safety. We had to take their permission. We had to go to the BMC office many times in 1.5 years. We had to show, basically ISA, we had our own references of our authors where, the sonography machine is used. And it took nearly 1.5 years to get permission. So I think the private practitioner, the hospitals which already have a sonography machine for some other purposes, they can at least attach their name to that machine. They can try that, going to the local authority, convincing and attaching their name to that machine. Hello?
It's not about the ISA alone. See, ISA can say the directives. We can easily say that you take the 15 days posting, something like that. But it depends upon your institutional heads also. It depends upon your HODs, your institutional principal or dean or director. You can do it at local level also. It's very easy. You make a roster, you request that you put up a roster and you post. It's a very simple thing. It's not a problem at all. Regarding ISA is there to help you out in every aspect. You bring the problems to the ISA, they will definitely help. But about these policies, institution, if you just ask the government, you just write a letter to the government, it will take, I think, years for an answer to come in the direction. Just like I told you in the beginning, that it took so many years. I think I've been hearing ever since I started these ISA conferences. All the people who are doing elections, and every person, I will bring UG into the curriculum of anesthesia, something like that. I've been listening this for the last 15, 20 years. But to bring it on a table is something different. Here we are focusing on the practical aspects. Yeah, it's very simple. Very simple means the HOD of anesthesia, you request a principal or a dean, just keep my PG's posting for 15 days to 30 days in the radiology department for seeing the blockage or seeing the landmarks or whatever it is. whatever the procedures under, there are many procedures which are done under the ultrasound guidance or even under CT or other radiological equipment. So it's very easy. There's no difficulty at all. The initiative has to be taken by the individual institutions also, not about the ISA alone here.
Yes. I think basically where there is a will, there is a way. That is what we can conclude.
What I think, sir, what I
Yes.
can say is that the university, if they can pass guidelines like they have done for the Rajiv Gandhi University in Tamil Nadu, they have passed guidelines making radio diagnosis posting as part of the curriculum. So the universities in each of these states have to come forward, not just individual institutions. I work in medical college. They don't have there is a fixed pattern of your postings. The university has to come out saying, I think that if that can work, then that would be great across India. That's my opinion.
I think things are improving as we are advancing in all the information technology. Things are improving very fast, and I'm sure these kind of hurdles are not a big deal. While if we have the motivation and the mindset of practicing regional anesthesia, these are just baby steps which we are taking. They will definitely result in success stories later on. Only thing which is important is definitely the mindset, and we have the backing of ISA regarding this. They are doing a lot of effort in improving the training and taking it to the private practitioners also at the grassroots level. I think one of the most important hurdle is also because they are not able to, they cannot take a break from their, from their routine. That is because they cannot take long breaks and for this training and these purposes. So that is also one additional hurdle. So these things, I think they are improving very fast, and we sure have a brighter future in this regard. So can we have a question to, even the audience can participate. I think I'll encourage the audience to participate and type their answers in the chat box.
Already there are questions in the chat box. I think Dr. Divya and Dr. Apurva should take care of those questions. They must have gone through those.
Yes, sir. I request Divya ma'am to please tell us the questions which are there in the chat box. Dr. Divya or Dr. Apurva?
Unmute yourself, Dr. Divya, unmute yourself.
Yes, thank you, Dr. Anju. Dr. Sunita Jain ma'am, she has asked about the age limit which has been limited to less than 40 for attending these trainings. So she is mainly concerned that why the senior anesthetists, they should be forbidden from this opportunity. So what is the say about it, sir?
Would any of the panelists like to answer this?
I didn't know there is a limit for this. There's a limit, age limit.
Actually, yeah, even I'm a bit surprised at this question that there is no age limit to learning.
Yeah,
I don't think so. There is any.
Sunita ma'am has just shown her this thing that there should not be an age limit of up till 40 years to attend these trainings.
I don't think there is any such.
Yeah,
there is actually the age is not a barrier to learning. The only thing I'm telling you, the problem will come. Suppose a person of 50 years is attending a class with a 30 years. Definitely, there's a gap. It's a generation gap. Your learning skills maybe slightly, the reflexes may be slightly lesser than a younger person. But sitting in the same class when the doubts are being asked, there's something embarrassment type thing can occur. A particular type with testing your knowledge and skills and questioning and answering session going on. So there was a solution to this thing also, that if you want to learn, let's have a class of 50 years plus, where everybody is of the same age. There is no ego, there is no clash, there is no embarrassment. Let's have a 50-year plus class, then has a 30+ class. You can have a barrier classes. So that learning has no problem. But the only thing is there is no age for learning. Many people learn at 65 years of also. But the only thing is about this atmosphere of the class, where the age generation gap is there. That is very important. And we should respect that. A person who has done a wonderful work throughout his life, and just suddenly wants to learn regional anesthesia. It's his courage to learn, and suddenly he should not be exposed to the question answer where youngsters can make a mockery of his learning process. That's very important. You have a class for the senior citizens, not senior citizen, middle citizens, I say. Middle citizen from 40 to 60 doctors are middle citizens only. Let's have a different class for them.
Yeah, I still remember in last ISA West Bengal conference, state conference,
There is a
It's
will.
nice to meet you. Human.
we had
If there is
a
a will to
ISA
learn,
boot
I
camp.
think nothing can stop a person from learning. I think if there is a will, we all have learned regional anesthesia. We didn't have any workshops also when we begin our journey in ultrasound. We just from internet or YouTube, these kind of sources. So if there is a will, there is a way. Dr. Ashit, would you like to add, because you have a extensive experience in training and teaching? So how can we improve these teaching activities? Because many of the older people don't have the knowledge regarding the ultrasound practice, so that remains one barrier. So older people will definitely be more reluctant in going ahead for these training things. Any of the panelists?
Am I audible, madam?
Yes, yes, yes.
I remember last time in our West Bengal state conference, we had a session called ISA boot camp, where all these private practitioners, those who are of this middle age you're talking about, they all came, and we had a fantastic session where over 100 participants of this age group, they participated. They all came from, they all said, because we are not very much aware of the newer techniques, those who are coming in daily practices. So we had organized one such session, and it was a great success.
So I think that answers the question of Dr. Sunita. So there are such kind of training activities being held, and there is no age which is which forbids the learning process. There should be a mindset and motivation. Yes, Dr.
And another question Dr. Lohit has asked. Dr. Lohit sir wants to know about the availability of lipid emulsion in the peripheral centers in case there is a complication or overdose of LA. So he just wants to know that in peripheral centers where there is paucity of resources, so whether there will be availability or not. So he just wants to know that about the availability of lipid emulsion there.
Very pertinent question. I think we all need the awareness of the importance of keeping the local lipid emulsion in our kitty wherever we are practicing regional anesthesia, be it a private setup, be it a very peripheral area, or be it a tertiary care setup. There is no denying that we have to keep ourselves safe, and lipid emulsion is now a necessity. Is anyone who is currently working in private practice, can they take up this question?
Dr. Anju, there is no need to take up this question. Actually, it's the very pertinent point. And when you are practicing regional anesthesia, whether in the periphery or the institution, you are aware that the toxicity has to be prevented with the lipid emulsion. The chances become much brighter to save the patient if the toxicity develops. So there is no second thought about it. But when you are already practicing, the first time you are practicing, you must be knowing that the complication develop, the availability of lipid emulsion should be there. It's not that costly also that you can't keep it, because even in the all the setup where you're practicing, suppose one person is going to 3-4 centers, he can make it available for when he's practicing the regional anesthesia. We have already dealt those questions where you were talking about the convincing the surgeon, convincing the patient, everything. When you are already convincing them, convince yourself first. Convince yourself first that you are practicing it safely. If you are practicing it safely, you are keeping it. So there is no need to ask this question to the panelists, why we have to ask. It has to be kept. When you are practicing it, because you are alone, you are single-handed. The surgeon will be busy with the surgery. If the toxicity develops, there will a very single assistant will be there who may not be well versed with the complication developed with the regional anesthesia. So you have to keep it there. There is no second question about it.
There is no second thought about it. Whoever, wherever is practicing regional anesthesia has to stock local lipid emulsion in their kitty. I think the thing here is that the awareness, how far we have been able to achieve this awareness that the lipid emulsion is that important. I think that will remain to see.
At this national forum, sir, I would just like to share a small experience regarding the discussion about PCP and DT Act. We are planning to have a workshop in our institute, and I've been struggling with the authorities to get this act for, we have an ultrasound machine for which we have the permission, but we want to hire one or two more with some companies. So we have approached the higher authorities. They are not ready to give us the permission in the name of anesthesiologist. They want per se the name of either the radiologist or the gynecologist. So we are facing this problem. So this forum has really given this platform and discussed about it. So what to do about it? I mean, this is per se my question, as well as one or two audience also they have asked about this, that how to go about it, sir.
So regarding this question, I have an ultrasound machine of my own. So we just have to prove them that regional anesthesia with the use of ultrasound is very useful, its advantages, and we have to convince these people that it is for the safety of the patients. And we have to show them how the conferences are held at different regions with the use of ultrasound, and they will be convinced. There is, I did not take much of the times to convince to take my ultrasound machine.
Dr. Divya, actually the problem is there in the different states. The strictness of the constitution is different. The interpretation of the constitution is different. Suppose somebody is practicing in Punjab, somebody in Maharashtra. You have a hell lot of a difference between the laws being imposed upon the anesthesiologist to practice with the ultrasound is different altogether. And even the punishment and other, other measures are also taken in a very different approach. So we had a discussion at that time. Dr. Asit Vaishnav sir was also writing about the CPND Act. At that time in Gujarat also you have a different circumstances. So it depends. I think Chandigarh has got much less, this strictness of norms as compared to Punjab, although it's a capital. So it varies from state to state. It is not a uniform. So that
actually,
is
sir, yeah, last week we conducted a workshop for thoracic regional blocks, and we got 3 sonocyte machines.
Yeah.
And within a week's time, we got the PNDT. We didn't have major issue. It went to the DHO district health officer and was done in a week's time.
That
and we were able to get the PNDT Act.
States having different problems because we rushed all the papers, required papers, the same sonocyte company. I mean, I got the paper release, the mail release from my medical superintendent also. It reached the CM office also, but still they say that we cannot issue it per se in the name of anesthesiologist. So even I was very surprised. Then we requested our radiologist and our gynecologist that kindly we can add your name in this. So again, there were some legal issues that if that machine comes under the permission of gynecologist or radiologist, then it will be an issue for our workshop. So we have to, literally, we are planning to rule out, to just not use that ultrasound and take care of what we have in our department. So that hurdle I'm recently facing.
I think the solution to that is involve your city branch representative from ISA. I think you should better work in a cohesion with the FOXY. You will better work with the Radiology Society of the city branches. Have a good cohesion with the city branches of different societies, because tomorrow they will be needing our services also. So just have a very good cooperative levels. I think these can be sorted out in the coming days or coming months. So very simple solution to these things. Otherwise, it's become always difficult to get the permissions. It happens in every conference. Every conference you have a problem with that when you are having this one workshop for the regional anesthesia.
I'm sure, sir, but I think the things are improving nowadays, because earlier there was a no to use of ultrasound outside the hospital premises. But nowadays ultrasound is being made available in even in hotels, wherever the conferences are being held outside the hospitals. It is now being available. So I'm sure the things, even the higher authorities will realize the importance. And with ISA coming up, I think the things can be sorted out.
Yeah, ultrasound machines, but if you have to take the permission to be used outside the hospitals or institutes, the getting permission is slightly more difficult as compared to when you're using it within the
now it is possible.
Now it's possible, yeah. But that problem even we faced in Chandigarh, though, like Bajwa sir said, it is not as strict. But if we have to do it outside the institute, it becomes a bit tougher.
Yes. But
well said, ma'am.
Let's see. I want to listen from Vaishnav sir also. Sir, unmute yourself and say some words of wisdom. Vaishnav sir, unmute yourself, sir, first. Unmute yourself. Vaishnav sir, unmute yourself.
Yes.
Yeah.
Getting permission or getting our machines.
Sir, unmute, sir. You are muted again.
But using ultrasound machines for regional anesthesia workshops, conferences is easy. Getting permission for outside the premises is very difficult. By law, ultrasound machines are registered for the room, particular room, say room number 203, where you will be using the machine. You cannot shift it to the room number 204. That is the legal requirement. And the Maharashtra people have faced very strict legal actions for these things. So better to as a practitioner, I limit myself to PNS guided blocks only because I do not have access to this ultrasound machines. We have tried getting permission for portable machines, and it is totally rejected. Right from BMC, Gujarat councils, everywhere, we do not get for portable machines. So for private practitioner, using USG of his own is out of question. If your hospital is having it, yes, you can shift it without any problem in your hospital premises, just adjoining room in ICU. If it is you are giving permission for ICU, you can shift it to your operation theater or induction room and all these things. It is possible within the premises without knowledge of authorities, but for a private practitioner, it is very difficult to use it. And I don't see there won't be any change in the legality of this PCPNDT Act in near future.
Well said, sir. Well said. It's actually the real scenario. If you ask me honestly, throughout India, pan-India, with the practitioners practicing with the peripheral nerve stimulators and hardly, I think, if you give a data, I think not more than 1 to 2% will have access to the ultrasound techniques in the entire peripheries here, on which this panel discussion is based upon. So those are the things. But I think without the practitioners, you cannot take the regional anesthesia to its zenith of safety and perfectness. So practitioners have to be involved, and their technique, I think a person practicing in the periphery with the PNS has got 99.9% safety as well as precision of blocking a particular nerve as compared sometimes to an institutional person with ultrasound doing that. So these things, the learning curves are different. We have seen it's a human nature, it's a human reflexes, the nerves, how they really acquire those skills and whatever it is. But the peripheral anesthesiologists who have been doing the blocks with the PNS, they are perfect. We have seen many such examples, and they always play safe. Every anesthesiologist, I think, I feel like that 99.99, not that 100% anesthesiologists feel that their patient should be safe. So they practice safe anesthesia. So they will definitely like to practice the PNS or ultrasound or landmark technique in the safest of manners. This is what I feel.
Absolutely. Thank you, Bajwa sir and Ashish sir, for your wonderful insights. Any other questions, Divya ma'am?
I think no, the specific question, the whole chat box is flooded with round of applauses for all the panelists, a wonderful discussion, and most of the points have been well covered. And about the trainings and all, many people have asked about the centers. That has been taken up well by our honorary secretary, sir, that the centers for giving such trainings are being, they are being built up in association with the ISA headquarters and at various state and city branches level. Each skill center will be equipped with that. That is what sir has already answered about it.
So that is, I think, the most positive outcome of this panel and information for our audiences, that we have a positive thing to take from this panel, that such kind of training are being planned for people who are sitting at a peripheral setup.
Very, very truly, sir.
Yes, like exactly the way IRC Indian Resuscitation Council has come up with different CRTC we call there. So like that, we can build up different CRTC sort of thing for these peripheral blocks also.
I think it is in the pipeline, and it is in the vision of Bajwa sir and ISA, and soon we will have some.
That's why these discussions were said, these panel discussions have been brought up. The idea is to bring the practitioner to the fore. They are practicing it, you will be amazed if you see the techniques of the practitioners. You will be amazed how fast they learn and how precise they learn. I'm not saying about everyone, but many of them practicing the regional anesthesia, people, they don't get exposure. They just do the technique for their own, livelihood for every day. And they think that it's not their bread and butter to go to the conference and present their work, something like that. People feel shy. People feel that, they may not be having that much theoretical knowledge to back up the evidence-based knowledge to back up their techniques and skills. But whatever the technical skills they have got in blocking a nerve or even in the anatomical variations, they are doing the things. It's wonderful. I've really seen with my own eyes the practitioner doing such a good job. But the thing is that this platform is there. ISA is doing now let the practitioners come to the fore, make such a platform that they contribute to the research, they contribute to the academics, they contribute to the practice of anesthesia in the periphery, so that we have a better atmosphere in the peripheries. ISA is committed to ensure safety practices in the periphery, provided we also get a reciprocal support from the practitioners. This is being done, and it is not a question of 1 day, 1 week, 1 month. It is a question of years. You have to bring them in a step-by-step approach, and slowly we will be definitely marching towards more common platform. For regional anesthesia is just one aspect of that. There are so many other platforms where we want practitioners to be part of the mainstream. So that is, I think, we will be successful in the coming years, not in months. In the years, we will be successful, and in doing so, we will be doing a wonderful job to our fraternity, to our specialty. And that is the aim, that is the vision. And definitely from these type of panel discussions, my idea was conceived, I think 5-6 months ago. Why don't we have Indian guidelines for regional anesthesia? Different culture, different barriers are there. So you definitely need Indian regional. Why you go for the European? We had a good panel discussion on that previously, why we are following the European or American Association guidelines. Why can't we make our, we have got so many talented people, so many academicians in our country, so many practitioners in our country who can contribute to those guidelines. So those things will be coming to the fore very soon. Guidelines from we will be inviting the people from definitely based on the merit to contribute to those guidelines. The Indian guidelines are definitely going to come on. We have already called them ISARA, Indian Society of Anesthesiologists Regional Anesthesia Guidelines. So those are definitely in the pipeline, and they will definitely come in a very, very short period. This I can assure from ISA side. And first of all, I'd like to again thank you all the panelists. Your knowledge, your discussion, the times you spent today for enlightening this audience is wonderful. I'm really indebted to you, and more importantly to our moderator, Dr. Anju Gupta, who was handling the session beautifully. And last but not the least, Dr. Divya and Dr. Apurva, you were there as a facilitator. You are facilitating this show. So I'm really thankful to all, and to all the seniors who have been attending, my GC members, Dr. Manoj, Dr. Manisha, and other GC members, whosoever are there, and senior most people. I'm really thankful to everyone for attending this session, and it was a very useful discussion, I think. And a recording will be available on YouTube, ISANHQ, YouTube at ISANHQ. It will be available after this session is over, so you can watch it later on. That's from my side.
Thank you, sir. Thank you so much.
Thank you.
Thank you so much.
Thank you so much.
And good night. And good night. Thank you so much.
For sharing their insights and knowledge. Thank you very much, everyone. And thank you, Bajwa sir, for such wonderful initiative. I think this is much more important than listening to the theoretical stuff which is there every day, because this is the grassroots level. We are discussing how things are done actually. So these practical things are much more important, I think. Thank you, everyone.
Thank you, madam. Thank you so much. Thank you. Yeah, bye for now. Bye.
Thank you.
Bye.
So let's end the
Thank you
session
very
by
much.
saying long live ISA.
Long live
Jai Hind.
ISA.
Yes, sir.
ISA.
Jai Hind.
Jai Hind.
Jai Hind.